I'll tell you, we have another great issue this month, beginning with an article from the New England Journal of Medicine on orforglipron, which is an oral small molecule GLP-1 receptor agonist used in type 2 diabetes. And joining us to discuss this article will be the first author. Then we're going to talk about another article from the New England Journal on weekly insulin. Really pretty amazing. This insulin is insulin F-Cetora, and again, we're going to be joined by one of the authors of that New England Journal article. Then we're going to discuss an article from Diabetes Care on the risk of thyroid tumors with GLP-1 receptor agonists. This is a retrospective cohort study. Then we'll discuss another article from Diabetes Care on the association of patient cost sharing with both adherence to GLP-1 receptor agonists and adverse health outcomes. And finally, we have Donna Ryan joining us, one of the authors of the New England Journal article on once monthly Maritide cafraglutide for the treatment of obesity, the Maritide study. This is pretty amazing stuff. Get ready. For our first article, we'll be discussing an article from the New England Journal of Medicine, orforglipron, an oral small molecule GLP-1 receptor agonist in early type 2 diabetes. And joining us to discuss this article is my friend and one of the first authors of the study, Dr. Julio Rosenstock. Dr. Rosenstock is a senior scientific advisor for Velocity Clinical Research, director of Velocity's site at Medical City, Dallas, and clinical professor of medicine at the University of Texas Southwestern Medical Center in Dallas. And more importantly than that, if you know anything about diabetes and if you've read almost anything important in diabetes, you're familiar with Julio's name. Welcome, Julio.
Well, thank you so much. You're always very kind. You're always too kind with me, Neil. But I'm all happy to share the data with you. It's always a pleasure to spend a little bit of time with you.
Yeah, it is. And before we jump into the methods and results, can you give us some background on what is orforglipron and why was it developed?
Well, I mean, GLP-1 receptor agonists are very well established glucose-lowering medications for the treatment of type 2 diabetes and also for obesity. And it's really a boom, a lot of enthusiasm, highly effective in terms of glucose lowering and also weight loss. And they all have consistent GI adverse events, but over time they subside. And due to peptide structure and the absorption consideration, these molecules, peptides, need to be given subcutaneously. But you are an excellent family physician. You are a real doctor. You take care of people. And if you ask somebody, you want to have an injection, you want to have an oral medication, most of the people will prefer an oral medication. But because of issues of absorption and degradation in the stomach, it's been a problem to give peptides. There's only one that semaglutide, but needs an absorption enhancer, and needs to have some restrictions in terms of how to take it. Orforglipron is a non-peptide, a synthetic non-peptide small molecule that can be given orally. And since it's a non-peptide base, it can be administered orally, and it has a half-life pretty extended of around 18 to 24 hours. So, and there's already a phase 2 study that showed that it's highly effective in terms of glucose lowering, reducing the A1C by 1.2, even by 2%, and also substantial weight loss. So that was a phase 2. What we tested is the first ever so far study in phase 3, where this molecule is in a clinical development program that is with the purpose of type 2 diabetes, and it's called the Achieve program. And ours was the Achieve 1 trial that was in drug-naive type 2 diabetes, early type 2 diabetes with not well controlled.
And that's just so exciting because, as you mentioned, the oral semaglutide medicine is so, in many ways, difficult to take. You can't take it with food and all of that. And this has the potential to really answer that question, the need for an oral GLP-1. What was the methodology in this phase 3 trial?
Well, as you said, they've done PK studies in healthy participants, and it shows that it can be taken in the fed and fasted state without any restrictions in terms of food. This was a randomized, parallel arm, double-blind, placebo-controlled trial where three dosages were tested: 3 milligrams, 12 milligrams, and 36 milligrams that were titrated slowly and gradually, starting with 1 milligram, building up to 3 milligrams, or building up to 1 milligram, 3, 6, 12, or 1 milligram, 3, 6, 12, 24, 36. So it was slowly gradual titration every 4 weeks in people with type 2 diabetes who have a baseline A1C of 7 to 9.5%, who were naive to therapy. They were on no treatment there, and with relatively short duration of diabetes, 4 or 5 years. So that's what I call it, that early type 2 diabetes.
And what were the results?
Well, the primary endpoint was to look at A1C reduction, but we also looked at the percentage of people getting less than 7%, less than 6.5%, and of course, we looked at weight loss. In terms of, there was a large study, Neil. We screened 875 patients, and they start and randomized 559 in those four groups. They stay in this study they completed the study in more than 90% of those patients. And the nice thing, as I said, they have a baseline A1C of 8%. And the reduction of the A1C was very robust. The 3 milligrams went down to 6.7, the 12 milligram to 6.5 and 6.4. So we had remarkable A1C reductions in terms of there was a 1.6 A1C reduction approximately. So people remember when we were happy when people got less than 7%. Now
Hmm.
we're getting down to 6.5%. And the nice thing, Neil, is that 75% of people got below 7%, and 62 to 66% got down to less than 6.5%, taking one pill a day.
That is amazing because I think back to Julio when you were one of the authors on the Treat to Target trial with daily insulin, and if I remember correctly, in that trial, which is almost 20 years ago now, with insulin, you improved glucose control to by around the same amount of A1C reduction, and not this many people got below, again, a very different population, but not this many people got below an A1C of 7.
Absolutely. I mean, those are the days that we needed that one single basal insulin in the evening to get the people who were not well controlled to close to 7%, as long they were consistently titrating, but it's still, if we were lucky, 40 or 50% got below 7%. Here we got 75% of the people go down to 7% and 65% to less than 6.5%, which is really nice. And with insulin, you got the weight gain. But with
Right.
this molecule, we got you haven't asked me, Neil, but they got weight loss.
I was setting up for that question. You knew it, Julio. And
Yeah.
and 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 what was the amount of weight loss? And then also, tell us about the other cardiometabolic parameters.
Yeah, sure. I'll tell you. But in terms of the weight loss, I mean, people who were on the top dose, they lost 7.9 kilograms, almost 8 kilograms, which means that these people got down to 6.5 and lost approximately 17 pounds.
Hmm.
So, in a dose-dependent manner, two-thirds of the people achieve more than 5% of weight loss, and one-third achieve a 10% weight reduction. But can you imagine when you have in front of a patient who just recently diagnosed 2 or 3 years of type 2 diabetes, was overweight with an A1C of 8%, and you give her one tablet that can get down to 6.5% and lost 15 or 17 pounds? I think that many people will be very happy with those results.
I agree with you. I think it ushers in many ways, a new age of treatment. Um, Before we finish up, cardiometabolic parameters, effects on
Sure.
lipids, etc.
Yeah. Triglycerides went down like 16%. HDL cholesterol dropped a little bit, like 4 to 7%. Non-HDL, I mean, but the HDL cholesterol went up by 4 to 6%. So LDL cholesterol dropped by 5%. So they were in the right direction. I mean, I think that the non-HDL cholesterol was reduced by almost 8%. HDL improved by 5 to 6%. LDL cholesterol reduced by 5%. Blood pressure also dropped. So I think that it's all in the right direction. You know, the systolic blood pressure was reduced by 5 to 6%, in the diastolic remained very, very stable. In terms of GI adverse events, is like you would expect for people who have are on a oral on a GLP-1 receptor agonist. So there was some nausea in 12 to 18%, diarrhea around 18 to 20%, and vomiting around 4 to 6%, which is pretty, if anything, perhaps a little bit less, but they tend to subside over time.
Hmm. So if we put it all together, your thoughts on this molecule, where do you see this fitting in if we were to look into the future?
I think that I mean, this is not the only one. I mean, there's a plethora of oral non-peptide GLP-1 receptor agonists. So we see a lot of those in development. So the future is very good because it will be a lot of competition. Hopefully, the prices is going to be less. There's going to be more access. But this is just another option that we can offer to people with type 2 diabetes. Some will prefer to just not to bother with one a tablet and go for one weekly injection. And once they realize that it's so simple to give one weekly injection, they prefer that. But this is has a promising to be highly acceptable. Now, if you ask me what I see my little crystal ball where I see these medications is as a first line therapy. I mean, the world will be much better and we will take care of a lot of people with type 2 diabetes if we can co-formulate this oral GLP-1 receptor agonist with an SGLT2 inhibitor, which I believe should be foundation therapy in type 2 diabetes. So you can imagine a fixed dose combination of a non-peptide, the small molecule GLP-1 receptor agonist plus an SGLT2. I think that we can take care of more than 90-95% of people with type 2 diabetes.
Wow. I'm speechless, and that doesn't happen often, Julio. Dr. Julio Rosensack, thank you so much for joining us.
My pleasure, Neil.
Next, we're going to discuss an article from the New England Journal of Medicine on weekly insulin, weekly fixed dose insulin efsitor in type 2 diabetes without previous insulin therapy, the QUINT-1 study. And we are privileged to have one of the authors of this study join us, Dr. Eden Miller, who is a primary care physician as well as a diabetologist and obesity medicine specialist in Bend, Oregon, and one of the authors of this article. Eden, welcome back again to our podcast.
Oh, thanks so much, Neil. Always a pleasure to talk diabetes with you.
It is. So can you give us some background for this? First, like, what is insulin efsitora?
Yeah, that's a great question. One of the things that's been a challenge, especially when we give basal insulin, is all of the inertia surrounding it, the titration, the adherence, the initiation, the fear of hypoglycemia. And so insulin efsitora is a very unique weekly insulin. Now, many of you probably listening here are thinking, wow, that's great. Weekly insulin, really overcome some of those. But understand that there's going to be some learning and some familiarity with insulin efsitora, because a weekly insulin's going to have a little bit of an onboarding or dose that might seem kind of a little foreign when we initially start talking about it.
Yeah, we're going to be talking about dosing in a little bit, and one would guess that there's something like if you used to starting with, say, Lantus at 10 units daily, one would imagine you have to start with at least 7 times that much, which is going to feel a little bit intimidating. Why don't we jump in? So, can you tell us about the methodology? How did they look at insulin efsitora?
The Quint 1 trial was insulin efsitora weekly versus insulin glargine, which we do traditionally daily. And so, in order to try to make this kind of an easier type of dosing algorithm, they started insulin glargine like we typically do at the 10 units, and then did a target glucose based on the investigator for a morning fasting blood sugar. And so, then in the insulin efsitora or weekly group, they were started with 100 units that was given weekly, and then at 4-week intervals or monthly they would analyze the patient's glucose and then accelerate from there with fixed doses to that target glucose, using additional such as 150, 250, and then 400. So both arms were titrated, but one was in the efsitora monthly, and then one was daily in the glargine, to compare it to something as us as clinicians is a known basal insulin.
So, what's fascinating to me about this trial is the innovation of using fixed dosing, starting at 100. You don't have to decide a lot. Then, if it's above whatever your target is, easy titration on a monthly basis with things that those of us in primary care can kind of take and run with. We're not calculating how many units to go up, but just monthly fixed doses. We have the 150, we have 250, we have 400, and then following things out from there. So really, I thought pretty innovative in its simplicity, thinking ahead to how this might be used in practice, which of course leads us to the question of how did it work? What were the results with regard to A1C when comparing this fixed monthly titration schedule with what we are used to with glargine?
Well, the comparators were what we call non-inferior. And so a lot of times the individuals, when we look at studies, we think, okay, what does non-inferior mean? It means that when comparison to glargine, the insulin efsitora had the same or similar. We don't use S words when we talk about drugs. We use non-inferior in relationship to the primary target of A1C reduction, as well as the rate of hypoglycemia. And so that is those individuals when we use this insulin, we're not going to be compromising control, nor are we going to be increasing the rate of hypoglycemia. But another point, Neil, that you brought up, when we talk about this fixed titration, and I don't want to use the word force, but remember, inertia is so bad in insulin initiation and titration. So this may actually solve one of those issues of getting people to goal. Not only that, it's also a testimony to, did you see the increments of change between the doses? And we don't see an excessive burden of hypoglycemia, even though we're marching through those different doses, because of how this formulation is. It is exceedingly stable and steady state and doesn't have peaks or troughs related to it. And so it gives us as primary care clinicians confidence in initiating and titrating insulin to goal.
Yeah, it's fascinating. And the average A1C for both groups was around 8.2, 8.3, and both groups got down to just a hair above 7%.
Mhm.
And so the results were consistent with what we'd expect with titration. But one of the things that you allude to is the fact that studies tend to do better with titration than we do in real life because of things like therapeutic inertia. And that inertia occurs both at the clinician end, but also at patient's end. This is hard. Can you
Yeah.
talk for a couple of minutes about kind of practical clinical implications and injection burden? It is not easy taking insulin every day.
No, in fact, we can kind of have a little bit of a prior improvement in adherence using GLP-1s. We went from daily to weekly as well. And so I think we think of insulin as maybe not a candidate for that. And so there are so many things that are going to come up. You mentioned the A1C reduction in clinical trial. It's kind of what we see traditionally. None of it is quite different. But one of the things that we're really interested in going forward with looking at insulin efsitora out in what we call the real world is to see maybe that real world analysis in the future. Because even though an insulin may perform as in the Quint1 trial, when we look at real world, we might actually see better because you have an insulin that you have to adhere to weekly. You're going to have a clinician that's going to be discussing about that kind of titration, like you start at this dose, just like we do GLP-1s. So I'm actually anticipating, we shall see, whether we might actually see better adherence to a weekly preparation of insulin because it kind of addresses a lot of the barriers that we're struggling with to begin with, the titration, the engagement, and taking every day. So I think we know that at the get-go that there isn't any differences per se. One's not superior or inferior, but rather they're starting from the same place. So the question then becomes is, does a weekly fixed dose titratable insulin provide some of the answers to some of the barriers related to insulin? So I think we're going to probably see even more data come out later in the real world analysis.
Eden, this is so fantastically exciting, and you and I have seen so many advances over the last, 20 or 30 years, and we're seeing another one. Dr. Eden Miller, thank you so much for joining us.
Thank you. Always a pleasure, Neil. Always enjoy your late breaking discussions.
For our next article from Diabetes Care, we are going to talk about the risk of thyroid tumors with GLP-1 receptor agonists. This is a retrospective cohort study. The authors sought to assess the association with GLP-1 RAs and the use and risk of incident thyroid tumors. It was a retrospective, active comparator, new user cohort study, and it used an International Administrative Claims and Electronic Health Records database. Participants included patients with type 2 diabetes with prior metformin therapy who initiated a GLP-1 RA versus new users of SGLT2s, DPP4s, or sulfonylureas. The outcome of interest was incident thyroid tumors and thyroid malignancies. Propensity score matching was done, stratification was done, as well as Cox regression analysis. There was a total of 460,000 users of GLP-1s, over 700,000 users of SGLT2s, over 2 million users of DPP4s, and over 1,100,000 users of sulfonylureas. So this was obviously a very large study. And what they found was that GLP-1s were not associated with an increased risk of thyroid tumors compared with SGLT2s, DPP4s, or sulfonylureas. Analysis using thyroid malignancy and including a 1-year lag period produced similar conclusions. John?
So Neil, I find this to be interesting. So we're 20 years into our GLP-1 journey, and it has always had this kind of medullary thyroid cancer as kind of part of its package insert. And so, a couple things. Thyroid cancer, about 40,000 cases of thyroid cancer in the United States, although it's on the increase, although mortality is not changing at all. And probably that is related to people incidentally are having thyroid nodules found because they're getting CAT scans of something else, and someone finds a thyroid cancer, which is a relatively slow-growing cancer in most instances. The medullary cancers are probably in that 1 to 3% range of that. So it's probably about 1,000 of these cancers a year. And whether some of these initial studies were just found because people were looking for things. And So this is a very kind of interesting study, and I liked that it compared it to some of the other kind of oral medications that we'll use for diabetes. A year ago, they had a large Scandinavian study that was in the BMJ, showed kind of similar things comparing it to DPP4s. In January of this year, the American Thyroid Association kind of came out and really said there's not a whole lot of evidence. There's a little bit of that asterisk is where these studies aren't completely long enough to show that this is a problem. The issue, I think, is that people doing kind of searches online, and I think people scare themselves about this, about taking these medicines, which can be really transformative, especially in the weight loss space, including the diabetes space, but especially the weight loss space, that people might deny themselves for some fear that probably just isn't true. So one would think this great study that we have, it's going to go right, and they're going to take that out of the package insert. But, I don't think we're going to see that. And we've seen a propensity of kind of data that has supported that, but there's always that little asterisk. And so whether this is going to disappear from the package insert, so we're not going to have to be answering these kind of questions about these kind of really good medicines. So we hope. So I think that this is just another log on the fire, that this is no more dangerous than anything else when it comes to medullary thyroid cancer.
Our next article is also from Diabetes Care and is titled "The Association of Patient Cost Sharing with Adherence to GLP-1 RAs and Adverse Health Outcomes." The authors sought here to examine the association between patient out-of-pocket costs and non-adherence to GLP-1 receptor agonists. That wouldn't be a surprise, right? But they also looked at the consequent impact on adverse outcomes, including hospitalizations and emergency room visits. This was a retrospective cohort study using market scan commercial data from 2016 to 2021. The cohort included non-pregnant adults aged 18 to 64 with type 2 diabetes who initiated GLP-1 therapy. Participants were continuously enrolled in the same private insurance plan for 6 months before the prescription date and a year thereafter. Exposures included average first day out-of-pocket costs for the GLP-1 receptor agonists, and that was categorized into quartiles lowest to highest. The primary outcomes were the annual proportion of days covered for GLP-1s and non-adherence, defined as not taking the medicine less than 80% of the time. Secondary outcomes included diabetes-related and all-cause hospitalization and emergency room visits 1 year after the initiation of GLP-1s. So, what they found was that among over 61,000 adults who initiated GLP-1s, higher 30-day out-of-pocket costs were associated with decreased adherence. Not entirely surprising there. Patients in the highest out-of-pocket quartile had significantly higher odds of non-adherence, about a 25% higher odds than those who were in the lowest quartile. Non-adherence was linked to increased incidence rates of diabetes-related hospitalizations and ER visits. Hospitalizations, an 86% increase along with ER visits. Cumulative length of hospitalization, 56% higher. All-cause ER visits, 38% higher. And increased emergency room costs. John.
So Neil, I think this is a fascinating thing that you and I talk about, and we have often marveled at all the amazing things that these medications do. And if you can get someone to lose a large amount of weight, a lot of problems can go away. Makes all the sense in the world. Also in the United States, we live in a country where 40% of the US population does not have $400 in the bank. If you look at these kind of medicines, and I looked them up on one of the things that we look at on our app for discounted medicines for patients, and depending on the product, somewhere between $12,000 and $18,000 a year for these medicines if someone's paying for it. An amazing amount of money. If you go back over a dozen years, there was about $17 billion spent on these medicines. If you go back to 2023, it was $71 billion. The projection is $105 billion by 2030. A huge part. I read one of the investment banks has predicted that all this weight loss will increase our GDP by 1% because more people will be working, more people will be more productive. I've also read that this is causing a hampering of business in kind of fast food and snack business and things like that, with people snacking less and not being as drawn to these empty calories. So it's this huge economic thing. Some of the patents on some of these things and some of those other things to drive the cost down. I think these are amazing medicines, and maybe with more and more people using them, it will drive the cost down, maybe like electric cars. But it also might just be that they'll be to a point that this is so life-saving for people and critical that there's going to have to be some pushback. So I think we need to figure out something, or maybe we need to figure out what's the end of this. Not that people are going to be on these forever and ever, and that's a little bit what we've seen in some of the guidelines. Or do we start having to look to say, boy, this is a great fix and we're going to do this over a certain period of time? But you and I talked about an article not too long ago about the cost effectiveness of doing a bariatric surgery over all the years. Is actually, it's more cost effective to do a big abdominal surgery than it is to put someone on a medicine forever and ever. So I think these are important conversations we need to have with our patients, with our partners, with our associations, and probably as a nation.
Those are good points, John. It's interesting. The thing that stood out to me here was how poorer adherence to the GLP-1s decreased costs for ER visits and hospitalizations, and there was an increased number of hospitalizations. It would be interesting to look at a comparative cost estimate of how much money is saved by paying for GLP-1s, and that amount offset either entirely or at least partly by a decrease in very expensive downstream needs such as hospitalization and ER visits. For our final article, we're going to discuss once monthly Maritide cafraglutide for the treatment of obesity, a phase 2 trial, the Maritide study. This is really covering new ground, and joining us to discuss this trial is Dr. Donna Ryan, who is one of the authors on the trial and throughout a just illustrious career has often covered new ground. Dr. Ryan is Professor Emerita at Pennington Biomedical in Baton Rouge, Louisiana, where she oversaw clinical research for 25 years. She is an author on perhaps more trials than I've read. She is a former president of the Obesity Society. Donna, welcome back to our podcast.
Neil, my very great pleasure to be here. Thanks for having me.
Sure. So can you give us some background on this amazing trial?
Yes, it is an amazing molecule. So what it is, it's a monoclonal antibody. We haven't really had one of those before as an obesity treatment tool. So we're really learning from it. So the monoclonal antibody is directed to GIP. And on that antibody, there are 2 GLP-1 molecules. So it's going to be doing 2 things. It's going to be antagonizing GIP, and it's going to be having agonizing or promotion of GLP-1 effects. The surprise there is that it's an antagonist to GIP. Our other experience with GIP is with tirzepatide, and that is a molecule that targets both the GIP and the GLP-1 receptor. It's a single molecule dual agonist. But this is not an agonist, it's an antagonist. So the first thing you do is scratch your head and say, wait a minute, how is this working? If you follow the science, and there's a lot of science by some very good sort of animal physiologists who know a lot about how these gut peptides work, antagonism of GIP does produce weight loss. Yeah, amazing. And so I guess the person who really explained this to me was Randy Seeley. I think everybody knows him who's in the obesity field. He's very good on helping us understand all of these gut peptides. But he said, yeah, GIP is an amazing molecule. And he says, if you're not paying attention, if you're not confused by this, you're not paying attention. Yeah, it's confusing, isn't it?
Yeah, it is. And I'm so glad you explained it that way because that was the first thing that stood out when I read the paper. And actually, when I was at ADA and heard you and the other investigators talk about the paper from the podium. So that makes more sense now, as much as I think it's going to make for most of us. So let's now go into the methodology. Can you tell us about the trial?
Okay, so this is phase 2. Neil, what you're trying to do in phase 2 is you're trying to get your dose and you're trying to understand how to best give your drug so that you can really do a phase 3. The purpose of phase 3 is about writing your label. It's about getting all of the data that's required by the regulators to get your drug out on the market. So this had 592 individuals. There were 2 cohorts. One was about obesity and the other was an obesity with diabetes. All of the patients with obesity did not have diabetes. They had prediabetes or normal glycemia and obesity. 592 people in those 2 cohorts, and they were given various doses of the combination. It's called Maritide. We're making it easy for you to pronounce it this time. So Maritide has a very long half-life, 21 days. Wow, that's a long time. And Randy Seeley showed us data that actually the efficacy is longer than you would expect for that 21-day half-life. So we're really interested in that part of it too. Anyway, it's very long acting. All of the monoclonal antibodies heretofore used have never been given with a dose escalation. We're probably going to need to do a dose escalation because of nausea and vomiting associated with the GLP-1 molecules attached to this. So one thing that happened in this phase 2 is we found that out. So the doses were initially given without a dose escalation, and there were high levels of nausea and vomiting. And so then there was a dose escalation, and that came down somewhat. The good news is that overall, the average weight loss, the mean weight loss at 52 weeks was up to 19.9%. Wow, pretty good. And the hemoglobin A1C reduction was 2.2%, up to 2.2% on average. I'm simplifying this for you because there were a lot of different doses.
Sure.
The other thing that was interesting about this is that the average weight loss in that diabetes cohort was excellent. It was mean weight loss of 17% on average. That's higher than we usually see in the patients with diabetes. But as I said, there were high levels of nausea and vomiting. This drug is being brought forward by Amgen. And so this is their first real experience in a metabolic disease like diabetes or obesity. And one thing they brought to this was a tool to help us better probe for and understand nausea and vomiting and retching associated with as a side effect. And this is a tool that's used in cancer chemotherapy and that they've used in their chemotherapy monoclonal antibodies. So it's called the MinVer. And the MinVer is asked questions. It's given daily. It's a questionnaire given daily. And it asks the patients, how many episodes of nausea have you had in the last 24 hours? How many episodes of vomiting have you had in the last 24 hours? And how many episodes of retching have you had in the last 24 hours? So very different from how we're usually assessing adverse event, nausea and vomiting. In the usual case, we just say, is there anything you need to tell me? We don't give them any clues about what we're interested in. We're trying to find, is there anything about your health or how you're feeling that you need to tell me? We specifically do not ask about nausea and vomiting. So of course we got high rates of nausea and vomiting, and we knew we had to do something with the dose. So we did what's called a PK low dose initiation study. And so we did PK studies along with this Minver. And we were able to track a very good quantification of nausea, vomiting, and retching alongside the PK. So there were 3 types of doses that were given: 21, 35, and 70. So 3 groups, each group had about 40 patients in it. The first day they got 21 milligrams, the other group got 35, and the third group got 70. Of the 40 people in that 21 milligram group, there was only 1 episode of vomiting, and there was about 20% that had nausea. The rates were much higher in the 35 and the 70 milligram dose. So that tells you that a starting dose of 21 milligrams is pretty good. Yeah. Now, when we did the PK studies, we saw that, of course, the PK, the serum levels really, the plasma levels really did correspond to the levels that we were dosing. And when we increased to the second dose, and on day 15, everybody got 70 milligrams, there was a big jump for that 21 milligram dose. And they had rates of nausea and vomiting that were the same as the 35 and the 70 milligram dose. And then everybody went up to 350. And after 70 milligrams, there weren't much problems at all with going up to 350. So what that told us was that we needed an intermediate dose between 21 and 70 and 35. And so that informs our phase 3. So I think the good news is we got a lot of information. We have a very active drug. The weight loss appears to be robust. It looks like we're going to need a dose escalation. There were no unexpected safety or side effects that we observed. And so we're very happy about moving into phase 3. The proof of the pudding is phase 3. We'll have to see that.
Yeah. Now, Don, a couple of thoughts. One, it's so helpful to hear how things evolve and the details you went in terms of knowing how dose titration is come upon is so helpful for those of us out in the trenches who use the medicine. The other thing, when I looked at the article that stood out to me, and tell me if my understanding here is correct, when I look at the curve or the trajectory of weight loss, when we get to 52 weeks here, and in fairness, compared to other trials, our other weight loss trials, semaglutide and tirzepatide, don't end at 52 weeks. They go out to 72 to, I think, 84 weeks. But at 52 weeks in this trial, that curve was still heading down with a very nice slope. So we expect more weight loss than we actually saw here.
Yes. Yeah. That is that continued weight loss is amazing. We don't know when it's going to stop. So there was a 6-month extension to this study, but of course we haven't seen that data yet, and we will not until next year. So in drug development, time is money. And so you don't get to get all the information that you'd like out of the first study. We didn't have the luxury of waiting for 2 years to see when the plateau would occur. But that 6-month extension is going to be very interesting. We're going to be really excited about seeing what happens there. But I think what this means for people in the clinic is not only are you going to be dosing people once a month, you can maybe dose them once every 2 months, maybe even every 3 months, because that long duration of response is something that we haven't fully explored yet. And so we're very optimistic about that. But yeah, we don't know where this is going to end up. And it does appear to be quite robust.
That is right.
Neil, the way the field is going, I think that tolerability is going to become more and more important. And that's why I was really glad to see a better probe for nausea and vomiting. Yeah. I think we're so excited about finally being able to get some weight loss with people. So for so many years, we had to satisfy ourselves with 5% weight loss, 10% weight loss. Now to be able to get a lot of weight loss, now I think we really need to focus on tolerability. You know, when patients take these medications, they can tell immediately that they're having side effects and things that are affecting their appetite and stomach emptying. They tell us about that. We need to listen, and we need to try to give them the best tolerability experience we can.
Donna, it is such a pleasure, as always, to talk to you. Your wisdom is something that all of us listening benefit from. Dr. Donna Ryan, thank you so much for joining us.
Oh, Neil, thanks for having me.
John, before we close, I want to share some important news with our listeners. As you know, in addition to diabetes, we've been covering the full range of cardiometabolic conditions, and so this summer, our name is going to be changing to meet that consistent mission. Starting this summer, 2025, our podcast will be rebranded as Diabetes, Obesity, and Cardiometabolic Update. I know, you're already thinking, and you're right. The new name is Doc Update, Diabetes, Obesity, and Cardiometabolic Update. You'll notice this when the change is made on your subscriber feed. We'll have a new title and branding, same great information. For more information and links to the articles that we discussed in this issue, just go to diabetesjournal.org. Until next month, keep listening
And keep learning.